Hello and welcome. You're watching a special program, a ZTN very special program. In fact, of course, this is ZTN Prime, and we're coming to you live from Harare, Zimbabwe. Hello, I'm Andy Hodges. Now, today's program, as I said, is a ZTN Prime production in partnership with the Poverty Reduction Forum Trust, PRFT. Now, what are the challenges faced by people with disabilities on accessing health services in Zimbabwe? What are some of the inequalities encountered in their health service delivery for people, as I said, all across the country, whether it be clinics, hospitals, any place where they can get health services? Today we're going to examine the challenges faced by people with disabilities in accessing health services, and hopefully we'll discuss what we can do about them. And to do that, I'm joined by what I can call quite an esteemed panel. I've got Judith Cowlem, she's Director Poverty Reduction Forum Trust, Dr. Christine Petter, Director for Disability Affairs in the Ministry of Public Service, Labour and Social Welfare, and of course a good friend of mine, Masimba Kuchera, Disability Consultant. Ladies and gentlemen, welcome to the show.
Thank you, Anthony.
Now, the Poverty Reduction Forum Trust, of course. Judith, I tell you what, before we get into the show, maybe just explain briefly what Poverty Reduction Forum Trust is, your mandate, what you do, and the work that you do in terms of bridging this inequality gap.
Thank you, Anthony. The Poverty Reduction Forum Trust is a civil society organization where we do policy advocacy that is informed by research. It means we engage with people, with communities, to get their voices that will influence policies so that they respond to their needs. Like in this particular case where we are talking about access to health, it's the voices of the people that we engaged with, so that at least we come in with lived experiences, then they can inform policies so that they are pro-people, they are pro-development. People are put at the center of what government does in terms of addressing the needs of the people.
I will ask you later on about taxing the rich, but one thing I did want to touch on you, because that is obviously a topical subject, isn't it? But one thing I did want to just for you to explain further, of course, is the Fight Inequality campaign, and we're in the Global Inequality Week, advocating for equal and sustainable world. I mean, that is a critical message, isn't it?
Yes, that is a critical message, because here we are discussing this particular issue about access to health. And we see a lot of inequalities. There are the haves and the have-nots. Now we are talking about a particular group which is marginalized, the people with disabilities. And then when we see the discrepancy between certain groups of people in society, there are people who are wealthy. However, they've accumulated their wealth, but sometimes they're not taxed enough. And if they were taxed enough, and those resources come back and are plowed into services like health, then it can help. So this week, really, that's the kind of conversation within the Fight Inequality Alliance.
I like that. And of course, let's call it a campaign, because the campaign is obviously about exposing the existing gaps when it comes to health delivery for persons with disabilities, trying to understand what prohibits them from accessing the health services of public hospitals, and also looking at the infrastructure, special aids and services that may suit their needs. So this is a campaign. So please get onto this campaign, because it is very critical. I mean, I think we worked out the numbers. 10% of citizens of Zimbabwe are people with disabilities, and that's a huge number. You probably have a relative, someone in the rural areas, and so it is in your interest to get involved in the campaign to bridge the inequality gap, particularly what we're talking about today, of course, which is access to health. Masimba, welcome to the show again, sir, and compliments of the season. Masimba, let's start with you. I want to understand, what exactly do you see as the challenges that you face, yourself personally, and of course, persons with disabilities, in accessing health care within Zimbabwe?
Thanks, Andy. So the access to health issues, I think, is a key one. And you can divide it into three. So there is access to infrastructure, access to drugs, and access to the services themselves. And when you talk about infrastructure, you'll discover that perhaps in some of the public hospitals and institutions, you do not have infrastructure that is disability friendly. So you're talking here about the buildings, you're talking here about some of the fittings within the health system. Personally, for me, it's access to drugs in terms of the cost of drugs, the cost of medication. And unfortunately, I don't think it only affects people with disabilities. I think everyone, when you look at the access to drugs, it's a serious one. And then access to services as well, to say, do we have sufficient numbers of health personnel trained to work with people with disabilities? In some instances, not. So if I were to summarize, that's how I'd summarize the issues around access to health.
Before I bring in Dr. Peter and Judith, the one thing that's interesting to me is that we need to, I believe we need to define the difference between rural and urban. I think that's important because obviously rural hospitals, urban hospitals, I mean, we'll focus on Paranatua and some of the other clinics and so forth in the cities, Masimba, but there are differences, particularly for persons with disabilities in the rural areas and urban areas. Can you highlight some of the differences? I mean, I know some are the same, but there are obviously differences, whether it be distance travel, with a lack of transportation, someone, say, in a wheelchair, they can't get to the hospital, site issues. Tell me, what do you see?
You know, I'm just afraid that we can then have the whole show to myself.
But no, don't worry. Well, don't worry. I'll jump in if I need to.
But when you look at the rural areas, I mean, people within the rural areas, especially people with disabilities, the issues of distance that you talk about are key. The issues even to do with their own mobility aids. Aids that they may use to move from one point to another, issues of transport. Even the cost itself, I mean, getting yourself to a hospital is not easy in some places. And then also do we have doctors and nurses within those rural clinics? Sometimes not, who will then be able to attend to the needs of people with disabilities. So these are key issues to do with, and then you also have still people who believe that people with disabilities sometimes must not have access to health. So it's also a cultural issue where our relatives, perhaps friends, also deny people with disabilities access to health. So it's also something that we need to talk about, to say, are we accepting of people with disabilities within our communities? In some communities, it's very difficult when you have a relative or a child with a disability. Some people still are hiding people with disabilities.
Yeah, we've encountered that stigma, which is unnecessary. Judith, let me come, because I wanted Dr. Peter to hear the issues and then to discuss it from the government.
I just want to add to what
Please.
Exactly. In terms of the rural-urban divide, as we talk about inequalities, mainly speaking to the new normal that was brought about by the COVID-19, where we saw services, everything going virtual. Well, it was a challenge for the majority of people, but it was a worse challenge for the people in the rural areas where there's no connectivity. We heard of the innovations that were happening across sectors, including in the health sector, where people can now connect with their doctor and they get the instruction over the phone or online. But people in the rural areas did not have that luxury. So really you see the inequalities widening. Yeah, and to add to what Masimba talked about, being it a cultural thing, in the perceptions that people have. When we were doing this study to look at the lack of access of health for people with disabilities in Mutare, we're hearing of stories of how when somebody presents at a clinic for maternal care, pregnant and living with disability, the kind of attitude that they are given, even by the health personnel. So this is interesting. They look down, if I can say that, or they don't give them as much service as they would. Beyond looking down, some people look surprised. You are pregnant, as if they're not a human being. Yes, if they're not a human being, right? So you see that the inequalities, they're also attitudinal, you know?
Well, in fact, that takes me to my question. And sorry, Dr. Peter, don't worry, Dr. Peter, you're going to have a long time to respond because there's lots of things coming to you here. But one of the issues as well, Judith, I want to talk about, PWDs, men, women, boy child, girl child, the inequalities, the discrimination, even amongst the subgroup. Forget about able-bodied, but is there discrimination between young PWD girls and boys and men and women as well? Does that also permeate into the inequalities in access to
I
health?
think Masimba will be better placed to respond to
Masimba,
that
could
one.
you respond to
Because
that? Because
otherwise-
Dr. Peter has a lot. That's why I'm keeping, because she's got a lot we're going to talk about.
Indeed, I think it's there. Mainly when you look at women with disabilities and girls with disabilities, they are discriminated more. When you look at a couple of months ago, we were talking about the 16 days of activism against gender-based violence, and there is a lot of domestic violence against women and girls with disabilities. Now, Judith talks about COVID. COVID meant that we were confined to small little spaces for longer than we usually do. And it also increased the rate of domestic violence or violence against women and girls with disabilities. And then compound that with limited access to health, then you have a serious challenge.
Dr. Peter, finally, we come to you. Finally.
I'm still here.
Right, so Dr. Peter, you heard, as I said, I wanted to keep you to the end because I wanted you to hear from Masimba's perspective some of the challenges faced by people with disabilities in accessing health services. We now talked about the rural, urban, and of course, Judith Cowlam here also talking, adding in about how her campaign, her organization is on this campaign to get rid of inequalities, and this week we're focusing on, obviously, access to health for persons with disabilities. Right, so your response. Let's start by the facilities in place. We talked infrastructure, we talked drugs, we talked services. From your perspective, I mean, you're the Director of Disabilities in the Ministry, your perspective, what's out there? Give us an overview of what you see out there from your perspective. You interrelate with person with disability organizations. Let me ask you that.
Thank you, Andy. I've been listening to what Masimba and Judith said, but I want to first of all point at this. This is a copy of the National Disability Policy of Zimbabwe.
That's the 2021.
2021, launched by our president on 9 June 2021. And this policy seeks to address, it's providing the roadmap for us to address the issues that have been illuminated by my colleagues here. And with a focus on access to healthcare, I want to say that serious frameworks on disability have begun to take shape in the country.
Let's go through them if you don't mind, because I think this is an important discussion.
Yes, Masimba has talked about access to physical infrastructure. I want to acknowledge that historically, persons with disabilities have been marginalized. And indeed, hospitals and clinics have been built for non-disabled people. Alongside an assumption that persons with disabilities have no right to access healthcare. But I'm also pleased to say that the government of Zimbabwe is taking serious steps to address these issues, and in a twofold way. Number one, there is need to renovate existing infrastructure. For example, make sure there are ramps to enable access by persons with physical disabilities who use wheelchairs. And number two, healthcare centers that are being built now are adopting an approach, a universal design approach, such that they are built in such a way that they are accessible to everyone, including persons with all kinds of disabilities. And that includes signage as well, access to information within those healthcare centers. Fine, we are addressing the issue of access to physical infrastructure, but what happens when the person with disabilities gets in there and they're deaf, for example, and they want to communicate with a nurse, or they want to communicate with a doctor.
Or they're visually impaired, they want to read something.
They want to read something. So we are talking about Braille, and Masimba will confirm that it's very important. And to provide signage as well in Braille, and also sign language interpretation services. But it may be difficult to have sign language interpreters located in all healthcare centers, waiting for deaf persons to arrive at the hospital. So it's a matter of looking at diverse solutions, number one, and in accordance with this national disability policy.
Well, I want to get to. I think I want to leave the end for the solutions. I think that's a critical part. But continue. You talked about infrastructure. What about the training of personnel in the hospitals? Because and of course we will talk about money at some point because we're talking money. Yeah, I mean unfortunately, and also the issue that you, as you said, you may not be able to have every health center. I mean, that would be the first prize, of course. Every health center, universal access to everybody. But maybe regional health centers, provincial health centers where we know that persons with disabilities can go where they're fully equipped for them. Maybe talk us through some of those plans. We'll talk about money. I know it's critical, but let's talk about the ministry's plans on that. Because I know the book is there and it's a very good book. I've seen it, and we'll go and we'll continue talking about it. But as we always say, great plans need implementation.
Yes. The ministry, and through the National Disability Policy, is directing that a minimum of 15% of healthcare students should comprise persons with disabilities themselves. Because imagine if you go into a hospital and you see a deaf doctor, a blind doctor, a doctor who is a wheelchair user, that is evidence of serious integration of persons with disabilities. The policy is also directing that the curriculum of healthcare professionals at all levels should include a module on disability. Because like what Judith said, she pointed at pregnant women with disabilities being shouted at by healthcare staff. And we go back to the training. Have they been trained on issues of disability inclusion? So that when persons with disabilities present themselves in healthcare centers, the nurses, they don't, they have to understand that.
It's in my mind, it's almost as if the nurses and doctors, they're just ordinary Zimbabwean citizens. They just happen to have disabilities. I mean, I'm trying, I always try and say this to people, is that, Masimba, I've known him for a long time. He's an ordinary, to me, he's a friend of mine, but he just happens to be with a disability. But it doesn't mean I must treat him separately or differently, but I must also be aware that there has to be special needs that he requires if he is coming for access to health.
Exactly. So in that case, we address the curriculum of the healthcare staff, and also for those who have qualified already, who have not been trained on issues of disability, continuous professional development, short courses that they can attend on disability issues. And Masimba mentioned the issue, he brought in a very important element of culture. And with regards, what is the ministry doing? The Department of Disability Affairs in the Ministry of Public Service, Labour and Social Welfare is engaging in a lot of awareness-raising campaigns, targeting families and communities in both rural and urban areas, talking about issues of disability and the rights of persons with disabilities, including the right to access healthcare. Because like what Masimba mentioned, the marginalization begins in the home, in the family, where if there is a family budget, priority is given to the needs of those who are non-disabled.
So they call that family inequality, I think. Internally, within your own loved ones.
Yeah, within the family. And then the healthcare of a family member with disabilities is put at the very bottom of the list of priorities of the family budget. So it begins in the family, in the community, to the healthcare centers.
Let me come back to you on that, because I see Judith wants to comment on the family, but I'm coming back to you because I want to talk about drugs and services and time limits and so forth, and then we can probably talk money as well.
Judith? Thanks, and I'm itching to...
Yeah, you were itching to jump in. Yeah, I could see that.
I'm itching to jump in and comment on what Dr. Peter has said, which is very important in terms of how, even at family level, the needs of the child with disability are put in the periphery. But then she goes on to talk about how it is difficult for government to situate maybe as a sign language person in every hospital, as if it's not a priority. So for me, I'm saying we see that at the household level, and we continue to see it at government level, as if to say it will be an unwanted cost for us to have somebody just sitting there to wait. But we have a physiotherapist probably just sitting there. We don't know
Waiting as well.
when somebody will come in with a broken leg. So I think if we are talking about the health as a right and a right for every human being, the government must be intentional about carrying that cost.
Masimba, before Dr. Peter comes in, Masimba, do you want to comment on anything that Dr. Peter said, and also Judith as well? I mean, the concept that, you know, should every hospital be equipped with with all of the necessary personnel, sign language, hearing aids, any of those, rather than say, well, you know what, we should only do one or two or this. What are your views on?
Okay, so I think there are two things here. The first thing is to appreciate that the ideal would be to have every health center with the appropriate, friendly access issues for people with disabilities. But I wouldn't want someone with sign language just to go to a health center and wait. I would want a deaf person to be the one administering these services within the hospital. So that makes more sense because then you have trained someone with a disability who is deaf, who is blind, and can offer the services and can share experiences with a fellow blind or deaf or physically disabled person. So when I look at it from a cost perspective, I understand that perhaps government should look at this more closely. But I think the approach that you should take, there are a lot of people with disabilities, some of them with qualifications, some of them who can be trained. And those are the ones who should be manning these places.
I mean, Judith made a point there, because if the mentality at government is that, you know what, this is something special, then already the inequality is inbred in us. Whereas rather than saying these are the facilities we should have anyway, irrespective, it makes no difference. And that the inequality is gone from our own minds, because it starts with us, doesn't it, Judith? So, Dr. Peter, you heard there the comments made.
Yes, I want to take the opportunity to correct, because I think there is a misinterpretation.
Please.
It's not like I'm saying there shouldn't be a sign language interpreter in every hospital, but I'm saying we should take a threefold approach. Number one, sign language interpreter. Number two, training, like what Masimba has said, deaf persons themselves to be healthcare professionals. That is why the policy is directing that healthcare personnel should be trained, should
That's
be
that
enrolled.
15%.
That 15%, that's where it's coming from. And then number three, the training of existing healthcare professionals on issues of disability, including sign language. Those who are there. So that we have begun to roll out training of healthcare officials on sign language.
Okay.
So that, because you don't necessarily have to be deaf in order to use sign language.
Yeah. I'm actually trying to learn it. We have a Maddie here, and I'm trying to learn from one of the colleagues. It's actually it's nice, actually, because you can talk. All right, let's talk about the two other issues that Masimba raised, which I'm sure, as you said, because the National Disability Policy issued in 2021, which we're hoping that you'll give us more of what's in it. Drugs, of course, he talked about access to drugs, but I think, as he said, it's a common thing for all of us. Drugs are expensive in Zimbabwe, and also US dollar based as well, a lot of them, because they're imported. And of course, the special aids and services, which suit the appropriate needs. Maybe talk to those, Dr. Peter.
Okay, I would like to say, with a focus on persons with disabilities, the government of Zimbabwe has a facility which is called Assisted Medical Treatment Order, in short, AMTO.
AMTO.
Yes, so through this AMTO, persons with disabilities have access to healthcare services. They get that order from, we have an officer and district social development officers in all the districts in this country, 65 districts. So it's through the district office that they get this order and access the healthcare free in public healthcare centers. But we also have situations where we have persons with disabilities who need, like, for example, major surgery for very complex health conditions. In such cases, the government pays, and it is our Department of Disability Affairs who facilitate the payment for example, oncologists in cases where somebody, and we have found that particularly among persons with albinism, we have a number of them who have cancer, and when there's need to pay.
So how does it work then? I'm a person with disability in the rural area, for example. I need a serious operation. Do I then approach one of your officers in the district to then put in an application? How does it, because I don't know if anyone knows it. I mean, when you told me about this AMTO, I was great. No, I was great because I haven't heard of it.
And I was actually confirmed that the awareness levels are very low. It's
yes,
there as a facility, but very few people know about it.
This
and
is
the process
point,
as well is also cumbersome. That's what we're getting from people. That the
okay.
process
Well,
itself-
let's address that. And Masimba, you know about AMTO, I'm sure, because I know you're an activist. But what about everyone else?
That's right. Yeah. So perhaps as we discuss and looking at solutions, how do we help the ministry share some of this
because that is a solution. You're
and
right.
perhaps how do we simplify the process as well, and so that it doesn't take as much time, because one of the things I think with AMTO is perhaps the time it takes, the requirements, 3 quotations, and so on and so forth. How can we try to simplify some of those things as well?
And also as well, you know,
And am I right, sorry, Andy, that it expires at some point, you are approved, and then at some point you have to reapply.
Why don't you take us to AMTO? Let's take us to AMTO. You know it, so take us through, because we're now hypothesizing, but you know the facts.
You go to the district social development office, because our district officers are on the ground. They're closer to the people. They're closer to the communities and the families. And we depend on them to also use their own discretion to make an assessment. And these are the officers who actually go into the families, into homes, and quickly alert us. I mean, through the provincial head and to right through to head office.
But what about this issue of it being cumbersome and long-winded, and the process is quite onerous? Have you heard of that?
No, I haven't.
You haven't,
because
okay.
the district social development officer actually has permission, authority to issue an AMTO at district level. And that is done in order to speed up the process. But we are also, Judith mentioned the issue of awareness, and we are raising awareness. For those who have access to the internet, for example, we are putting all our programs are on the internet, on our website, and where the Department of Disability Affairs is also, there is like a whole list of the services that the ministry offers.
Okay.
And then we have also engaged in outreach programs where we physically go to
Because do you have a register of persons with disabilities in certain districts? And your officers, do they have registers to know who the houses are so they can visit households if they need to?
Yes, we do,
Okay.
but we don't have the capacity to just visit them like at leisure. But where there is a problem, we have the means and the capacity to immediately respond.
Judith, it's interesting about access to health, because we're talking here about the facilities, the aids, and so forth. And we always, again, are making an assumption that the person with disability has an able-bodied person with them, but actually they could be very independent and live on their own and live their own lives as they should do. You don't need to be relying on someone else, because that just creates an inequality stigma. So, and then there we have another issue, don't we? Because they have to know that they need the right aids to the braille, they need the hearing aids, the things, because they have to do things on their own. That's also an inequality in itself, right there. Is it not?
Yeah, it is. It is. It is, and that's why I think we need to take a very multifaceted approach and take a very rights-based approach. For me, I think that's the bottom line.
Rights-based.
To look at a person as a person.
Yes.
The disability is a secondary issue.
Exactly.
So whatever it is that we do, if we are looking at an individual as a person, even when we are talking about investing in health, we are talking of universal health, which will then accommodate everyone. Because actually, and what is interesting about disability is it is not confined to those that we are counting today. Any one of us can...
I could lose a finger or a hand or a foot from an accident.
So
could be able to...
So I think if we plan whatever it is that we are planning with the view that we are doing it for all. We are talking about the Sustainable Development Goals. We are talking about the clarion call, leave no one behind.
Leave no one behind.
And we are talking about, especially now in Zimbabwe, with our president pushing for Nyika Inovayo.
It's true.
Masimba and I and you, Tisu Venovayo,
Yes.
and Itka. So whatever it is that we are doing it as a collective.
Agreed.
The disabilities are really a secondary thing, yeah.
Dr. Peter, your book, let's get back to National Disability Policy 2021. No, because I know it's right there. And guys, please go get a copy of it. I'm sure you can find one if you are content miss. You may have to pay for it, but there it is.
Yes.
Let's talk in there. Let's expand further in that policy about access to health and inequalities for persons with disabilities. Is there anything more you'd like to add in terms of what's in there? Because then we'll talk about implementation. I also want to ask Masimba after this whether he's seen any difference in access to health based on that, on the national disabled policy. Please highlight some of the issues that may be in publication.
Andy, Section 3.7 of this policy is dedicated to health. Yes, and the health and the well-being of persons with disabilities. And this is where the issue of training healthcare staff comes in, the issue of also ensuring that persons with disabilities themselves are enrolled in these training programs of within the health profession, nurses, doctors, etc. And
What other specifics?
Healthcare centers must be established closer to the people, where the people live.
Okay.
So this is not, I want to acknowledge, this cannot be done like in one day, but the roadmap is there. And we are moving towards bringing healthcare services closer to the people.
Okay, so can you highlight to me, to us now, and to the viewers,
Yes.
the progress, specific progress you've made? Because we can say we're getting there. Obviously, yes, it is a long step. But if I had to say, in 2020, there was only 3 hospitals with like this. Now there's 15. Have you got any numbers to give us to show that government has seriously started moving? Even maybe a step-by-step process. Have you got any statistics for us?
I don't have statistics
Okay.
at the moment, but what I know is there is a healthcare facility in every district, but the government of Zimbabwe is moving towards improving access. And also, we are addressing issues of informed consent, because you see that we have a challenge where when persons with disabilities are being attended to in healthcare centers, certain procedures, or family members will just say, for example, sterilize this person, because we don't want her to have children. It's a problem. And when they have children, forgetting that the UN Convention on the Rights of Persons with Disabilities is very clear that persons with disabilities have a right to decide on the number and spacing of their own children.
Because they're people.
Because they're people.
I mean, this is the point we're always getting back to, Masimba, isn't it?
Yes.
It's almost like people with disabilities are a separate sub-breed and we shouldn't. No, it's just wrong. I mean, let's be clear.
So it's like, because this policy, going back to the policy, it's saying no procedure, healthcare procedure, should be undertaken on a person with disabilities without their consent. So if my mother takes me to a doctor and says, sterilize my daughter, I don't want to have her to have children because she has mental disabilities,
You
it
have
will
the
be a
right
problem.
to refuse.
You see.
But then
And
again,
it
we're
is
back to the family thing, because you refuse as a daughter. Next thing, you're thrown out of home. Because they in other words, they use their patriarchal society, if I can call it that, to inequalitize you. I don't know, because that can happen, can't it? That fear.
That's a new
So
technology. I'm going to pick on that.
There we go. Yeah, there we go.
So the onus is on now. That's why we are taking a multifaceted approach,
Right.
where the onus is on the professional, the ethics of the healthcare professional who has been trained to ensure that, does this person have the capacity to give free and informed consent? Have they given free and informed consent? Or is the mother who is pushing?
Got
So
that's one area in that code.
In
To
that
inform
policy.
consent. That's important.
very important, because then the professional has a right to then inform the family member that, sorry, I can't undertake this procedure. if this person has not
And even the right to
consented.
privacy. I mean, you know, it's just an equality we're talking here. If a person with disability goes into the doctor, they want to be told things privately. They don't need their family member standing in the room wanting to know, because it's their medical history. It isn't mine plus my mother plus my uncle plus my, you know, Sekuru. It doesn't work.
Plus the Sekuru, no. And also, we are saying this policy is directing healthcare professionals to say they must allow more time to
Right.
persons with disability, because disability requires much more than clinical facts to understand. So you can't just rush the person.
Right.
And sometimes, depending on the nature of the disability, you may find that a person with intellectual disabilities, for example, they may take time to remember things or to connect things. So the healthcare professionals have to be patient.
That is a point. In fact, we did a story recently. I did a story recently about challenges of persons with intellectual disabilities, and a lot of focus hasn't been put on those citizens of ours. But it is important. You're right. They're mentally challenged. They may not understand certain things, and they need to be handled. But please continue, because I will after this. Anything else you'd like to highlight in that?
Sign language services for deaf persons,
Okay.
including in child delivery wards, where we hear that we have had, and research is undertaken, and through consultations we undertook on the policy, that deaf women say, then I can read the nurse lips, for example. The nurse is saying push, 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 but I want to communicate back to the nurse, and she doesn't understand sign language.
Yeah,
and
because something could be wrong or medically, and you want to
Exactly.
tell the nurse, but the nurse doesn't understand you.
And
this is
maybe-
inequalities for sure, isn't it?
And maybe the rule there is only your husband can get into the delivery ward. But what if I don't have a husband?
Yeah,
You know,
exactly.
to interpret, you know, can my aunt not come in and interpret during the child? The policy is addressing issues like that.
Okay, okay.
So, and like we hope to see a lot of change. It's a paradigm shift in the country.
I hear
And
you.
as I've said, serious frameworks. on
But these
disability.
conversations and the campaign that PRFT is running, this is what we're doing. We're conscientizing, we're paradigming shifting right today. Well, we're starting.
Exactly. And the policy is calling for collaboration
Right.
between the formally trained healthcare professionals, traditional healers, and religious prophets. Why? I'll give an example. For persons with mental disabilities, they are in a hospital, and then the family members will bring in some concoction from the traditional healer. They hide it from this psychiatric doctor who is, and then it's a mess. And then they tell the person with mental disability not to take this medicine secretly and take that concoction.
Right.
So the policy is saying there shouldn't be any secrets. The psychiatric the psychiatric doctor should be aware of what is going on there. So once there is no antagonism or suspicion or fear and everything is in the open, then we all know what we are dealing with.
I want to, sorry, because I want to bring Mr. Judith, then I'll bring Masimba in.
I just wanted to find out from Dr. Pet. I think the policy is brilliant. It says all the right things that will take us in the right direction. But what would underpin is implementation. Is the legislation, laws.
Is it legal? I mean, we've got the policy. Is there legal laws to back it
in
up?
terms of to back up.
Because it's all well and good saying 15%,
Yes.
which is fantastic, okay? But then the problem now is that if you only get to 7, you get to 5, if you don't do anything, it just becomes, let's try and get there.
Yes, we do have. I'm very pleased to say we have a Persons with Disabilities Bill,
Yes, perfect.
which is going before Cabinet in this first quarter of 2023.
Excellent.
And that bill, once it's enacted, and then it will go through further processes,
Yeah,
which
the usual
include
process to Parliament.
parliamentary
So we're looking at probably the second
consultations.
half of the year.
Second
Touch
half of
wood.
the year, I'm positive we will have a new Persons with
Well,
Disabilities
I think
Act,
I think it would be
which
nice to look at
enforces
that act
the
and
policy.
discuss it as well to see what's in it before it gets passed.
coming.
No, I'll tell you why. Because
It's on the way.
because sometimes when we discuss it, they can make changes before it gets passed. Masimba, I'm coming to you. You've heard. I wanted you to hear Dr. Peta. I'm sure there's more she's going to come to in terms of the policy. But I suppose the question has to be to you. Here's the National Disability Policy as it relates to health and access to health for persons with disabilities. Have you seen any change on the ground? Have you seen this policy implementation affecting PWD's lives when it comes to access to health and inequalities, fighting inequalities in the health sector?
So I have, and perhaps not as much as I would want to see. But the first thing, I think, it's awareness of people with disabilities in terms of their rights. And the policy is clear then to say these are the people with disabilities' rights. So part of the function of the policy is for people with disabilities to take it to everyone and say, look, this is your get out of jail free card. If you know what's in there, you are better placed to be able to access better services. And I think this is the change that we've been looking at. A lot of people now know about the policy, understand the policy. Perhaps we need more people who will then be able to use the policy, go there and use the policy within the health centers. So I think it's important. Let me tell you why the actual...
Before you go, is the policy known by all your health workers? In all, I mean, is it known or is it just a policy that's sitting in head office somewhere? Sorry, no, I will come back to you.
No.
I'll talk about the efforts we have made. We have translated this policy to the 16 official languages that are in the Constitution of Zimbabwe. We have it in Shona, we have it in Ndebele, we have in different, in all those languages, including in Braille and Sign Language.
Okay.
And we have embarked on a program of raising awareness in all the 10 provinces of Zimbabwe among duty bearers, that include the healthcare staff, and also family
the end user, if I can call it that, so to speak.
So
I just needed
we are making progress.
Brilliant. I needed just clarity on that because it's important. Because if the policy is sitting somewhere in head office, it doesn't really help anybody. But anyway, carry on. Sorry, Massimo.
So I was saying, for me, it's important that we have this policy. It's a starting point because before then we didn't have anything. So part of the progress is then to have more and more people perhaps accessing AMTO through this policy and through other mechanisms already there. Up to 2021, we didn't have anything apart from the Disabled Persons Act of 1992.
No, well,
so
imagine.
We have now moved to 2021.
Some of us weren't born, he says.
Yeah.
No, I understand. So it's a step forward, as Dr. Peter said.
I think so. So in terms of, I think the key is then the frameworks that Dr. Peter is talking about, to say how do we contribute to the development of these frameworks on the ground as people with disabilities. And I'm happy to say that we've been able to access Dr. Peter's office a bit more freely. You don't go there with the fear that she will chase you away.
I can see that already. Yes, I can see that even here talking on the program.
And I think that's a good thing, because there was also a disconnect between administrators and people with disabilities. So that disconnect needs to be dealt with, because part of the service delivery problems or access problems are caused by the disconnect between people who are supposed to administer the service and those who are supposed to get the service. The students are saying to say, if the nurse is saying, how did you get yourself pregnant, then you have a problem.
You went here immediately. It's like because you're sight impaired, how did you get yourself pregnant?
So that's the disconnect that I hope is also part of the implementation of this policy.
All right, well, let me just say that, of course, this is a ZTN production, and of course it's brought to you in partnership with the Poverty Reduction Forum Trust. And why this today is important is that, of course, the Poverty Reduction Forum Trust is focusing on the accessibility of health services and provisions for people with disabilities, and they really have got a campaign going to raise awareness to fight the inequalities, particularly as it comes to the health sector. And this week in particular is important because, Judith, I want to ask you two questions. The first question, of course, is we alluded to it earlier. This is the issue of the theme of taxing the rich. It's a very popular thing. The rich hate it, and everyone else likes it, and they hardly ever get taxed anyway. But talk to me about how that is the theme and how that's supposed to be achieved.
Thanks, Andy. Maybe just to allude to the Fight Inequality Alliance. That is not just Poverty Reduction Forum Trust. It's an alliance of many other organizations in Zimbabwe, Zambia. It's regional. It's actually a global Fight Inequality Alliance. And this week is the commemoration. So when we are talking, and for us, we want to tie in the issues raised within the Alliance campaign on inequalities, focusing on access to health, based on the work that we have been doing. But when we come back to the theme, which is taxing the rich, I know, Andy, that there is a wide-ranging debate among economists. It's not as easily achievable as we want the agenda to be.
And it also isn't like tax the rich and the money suddenly goes to all these things. Life is not that simple, unfortunately.
Exactly. But to start with, it's even the debate is around how do you do it? How do you tax wealth? Right?
Yeah.
And are there going to be tax reforms? At the global level, that debate is raging.
It's happening, you're right.
So really, the whole idea is for us, as the Fight Inequality Alliance, including the PRF team, is to say we put academics aside. But if we were to tax the wealthier, because we know that in most cases, these people, either they even evade tax, where they pay,
or their loopholes are there.
And when they pay, they don't pay taxes.
We won't talk about an famous American who pays zero
when
tax.
they do pay those taxes, they're not commensurate with the wealth that they have.
Exactly.
But if we were to address it by whatever approach the economists agree on, we think it will address the root cause of the crisis, the inequality. Because we know that households with persons with disability, they have to live on out of pocket. I'm sure Masimba will attest to that. Most of the services are not catered for by either public or private funds. So if the taxes, if there is a way of taxing the rich, and those resources boost public purse, then and they are used effectively and efficiently towards the services that we are talking about, including health, then we have a redistribution not only of wealth but also of power within our communities.
I want to talk about it because now we've got, because I wanted to ask you about the developmental implications, but we're now at the money, the money stage of this. And I remember Masimba, I had Masimba on the show after the 2023 budget. He was an analyst looking at the budget as it related to personal disabilities and if it was enough. And frankly, and I know we had a debate about it then, if you look at what we need to do to reduce inequalities in the health care sector for persons with disabilities, the money given is definitely not enough. I mean, I think we can agree on that, correct? I mean, it's just, because, what was the amount, Masim? It was, I mean, if you look at what we have to do in the health services for persons with disabilities, it just isn't enough, is it?
No, it's not. It's not. I don't think there was
even a mention of it. I think it was more this is the amount.
Monies for health in particular, but and I think that also then becomes part of the problem to say perhaps issues like health, access to health for people with disabilities should have earmarked funds, because if the money is coming to the department to deal with AMTO, then to deal with loans for people with disabilities for their projects, and to deal with other things, perhaps then we need to look at how do we allocate resources to health.
Like specifically for these issues.
Yeah.
Dr. Peter, I just want to comment quickly on the money side, because I don't want to ask Judith about developmental. And of course, the way forward, as I always like to say, it's always good talking about things, but we also want to know what's going on. So money, it wasn't enough. I mean, you talked about step by step. I'm sure if you had a lot of money, you'd be leaping and bounding. You'd be a sprinter. But because of the money, you have to take little steps. Talk to us about what you require briefly.
I will point again at the policy that Section 4 of the National Disability Policy talks about money, which is the implementation framework. As part of the implementation framework, and it presents different ways of fundraising for disability, including healthcare. There is the issue of taxing a levy, a disability levy.
Similar to the AIDS levy, if I can.
Yes, but it's a disability levy, which is then deducted from every litre of fuel sold.
Wow, that would be...
Because then that we of course modalities, we are shaping the modalities for implementing
as long as it does come directly to you rather than goes into the general accounts, because then
so the levy on every liter of disability,
that would
and
be
then
excellent.
we also
I think
have
people that would be great.
and we have our disability fund, which is already we get funds from Treasury, and we also look at our development partners. We do work with a lot of
so you're complementing what government can give you through scarce resources by approaching like-minded partners, trying to see how you can raise through
UN
taxes
agencies,
and so, try just to make enough money. Because again, we're talking inequality and health for persons with disabilities, but of course there are all other issues that we're not going to discuss today that you have to look at for persons with disabilities, where inequalities exist, whether it be education and so on. So that's important. Judith, I want to come to you about development. Then we can finally roll up by each getting your views of the way forward. Developmental implications. This people forget this aspect of it, but it's there and it's important. Speak to us to this. Speak about that.
Thanks, Andy. Because we are talking about health, right? Health itself, it's important. It's important by itself because then it enables one to live a good life. In life of full life expectancy. In Zimbabwe right now, I think the life expectancy is estimated at 61 years. But if somebody is not to reach that age because they were not able to access the medical attention that they wanted, because of inequalities, then that's wrong. And we are saying societies develop when more people are productive. And it is estimated that 1.3 billion, that is 1 in 6 people worldwide, live with some form of disability.
Wow, that is a huge number.
Yes, and we know that persons with disabilities are also at higher risk of comorbidities. Some of these morbidities are as a result of poverty or social exclusion. So imagine if this huge number, actually I think Zimbabwe is estimated at 1.4 million.
9.2.
Yeah, let's say 10% of the population has some form of disability. That's
And
a lot of people. In fact, it's unbelievable.
Yeah, we are not saying by virtue of them being living with disability, they cannot be functional.
No,
but we are saying because they are at high risk of comorbidities, which might require medical attention or rehabilitation attention, but because of these challenges that we are talking of inaccessibility, if this huge number is not contributing to the growth of the nation, not only does it prejudice the individual, but the whole community.
100%.
Yeah, so it is important that we are looking at persons with disabilities, like I said earlier, as persons, as human beings.
Exactly.
Yeah, so
a huge part of our community and
so
society.
Because if somebody has not been able to access medical needs or rehabilitation that they want, and then they are unable to access education, they are unable to access livelihood opportunities, they are unable to be active in the community, it means then they are not contributing. Then they end up being in poverty. And we know the vicious circle.
Yeah, that becomes a burden on the taxpayer rather than contributing
exactly. And the vicious, even
at
at the family level, because if this is a family that is encountering all these problems, and they have children who are not able to go to school because the parent is not productive enough, then
inequality gets bigger and bigger.
It gets bigger and bigger, and the vicious circle continues.
And that's the circle that we need to
exactly. And we need to have a more holistic approach to say it's not just the individual. Eventually, because they are a component of a society, of a nation. So it's all of us. So if we are talking about leave no one behind, let us actualize it.
And let's all of us walk that talk.
Exactly.
Because we say leave no one behind, let's not leave no one behind. Now, we are wrapping up, unfortunately, and I always say these subjects are so close to my heart that we could talk all day about them and other issues. But let's talk about the way forward. What I'd like to do is start with you, Judith, come to Dr. Petter, and then finish with Masimba. The way forward. We want to eradicate inequalities and healthcare access for people living with disabilities. In fact, our heading today is challenges faced by PWDs in accessing health services. What would be your, just we have a few minutes left. Your recommendations on the way forward, Judith.
The recommendation, I'm saying we are already at an advantage point by having this brilliant policy. So really for me, it's translating it into reality. And I'm glad that Dr. Peter is talking about the bill that is forthcoming. So let's actualize that. But let's not do it without the people concerned themselves.
Consulting,
and
consulting.
in the sector, you have the theme, is it a theme or slogan, Masimba, nothing for us without us. So I think the
It's a slogan,
involvement,
yeah.
yes,
I do like
the
that.
involvement,
Nothing
for us
without us.
Without
Oh,
us.
I like that very
yeah.
much.
So I think let's get that involvement. And as civil society organizations, our role is to complement what government is doing through awareness raising, through doing projects that also complement what government is doing.
It's working hand in hand, isn't it?
working
All of
hand
us
in
working
hand,
hand in hand.
exactly.
Dr. Peter, you got your policy there, and we always say we write great policies and great documents in Zimbabwe. Implementation, Judith said. What would be your recommendations on the way forward, looking at from the perspective of your ministry?
From the perspective of our ministry, and in particular the Department of Disability Affairs, I would like to speak to persons with disabilities themselves, families, and duty bearers, the healthcare professionals. I would like to say to families, family members should not marginalize persons with disabilities, and they should not put at the bottom of the family budget access to healthcare for persons with disabilities. To persons with disabilities themselves, I want to say that we have moved from a charity model to a human rights model, where the Department of Disability Affairs in the Ministry of Public Service, Labour and Social Welfare is seeking to empower persons with disabilities so that they have access to formal employment, they have access to entrepreneurial projects, they can start their own projects, and actually there's a loan, an empowerment loan, which we are administering through the National Building Society. As you have said, Andy, before, that a person with disabilities is not a sick, passive person who should just sit around and wait to receive donations and for other people to decide whether they should see a doctor or not. So I'm saying to persons with disabilities, rise. And with the support of the department, reach your maximum
And of course,
potential.
AMTO as well, which is important in terms of people that need help in terms of paying their bills for large operations.
Yes.
That's important.
We have AMTO
And
as well.
awareness campaigning as
And
well.
awareness campaigning. And two duty bearers, professionals in the healthcare system, in the healthcare delivery system, who may say, oh, but we haven't been trained on issues of disability. I want to say, persons with disabilities are the masters of their own experiences. Talk to them. And you will understand how a person experiences epilepsy, for example. And you begin to understand how a person with who has a spinal cord injury and who is a wheelchair user, you begin to understand the issues that relate to that person's
So in
kind
other words,
of
it can also, you don't need to then go in formal training. Without formal training, I don't know. Talk to people.
Talk to
Sure,
the
you may
people.
need the training, but you know
Yes.
what? You're health professionals, you care about people, you care about whoever's coming to you, so
Yes.
you speak to them and you find
They
out.
are the masters of their own experience.
I like that. And of course, the implementation, as much as we can, as soon as we can, to implement the health segment of the National Disability Policy.
And we have already begun.
And you've already begun.
Yes.
Masimba, you have the final word. You've heard everybody. Your recommendations, we have a couple of minutes left. Your recommendations on the way forward of how can we bridge the inequalities when it comes to persons with disabilities, access to health services.
First of all, I think it will be important for government to collaborate with people with disabilities. And I think that has started. That has not always been the case. Perhaps shows a bit of my age. But that has not always been the case. But I think that is changing. And it's key for me because in terms of then the solutions, practical solutions, we can be able to work together.
Yeah.
You don't want a situation where that disconnect I was talking about then comes into play to say they're just doing... So the charity model, the movement from the charity model to a human rights model is important.
Yeah.
The second issue in terms of recommendations is that today we are talking about fighting inequality and this week. In the same way that we talk about the 16 days of activism against gender-based violence, is something that we need to be thinking something that we need to have at the back of our minds all the time.
365
That's
days
right.
a year.
So it's not something that perhaps we do today and then
Next week it's another week of something else. Yeah.
So it's something that we always
But I think this is
need
where
to
your
have.
inequality consortium and all of you come in. You are continuing in this. This is just to raise awareness today, but this is going on.
Indeed. And I think the last recommendation is to ensure that for us as Zimbabweans, I think it's important that we start looking at people with disabilities as people who can also then be productive. If that happens, you are then going to reduce the number of people that government has to take care of, but also then increase the amount of money that government will be able to earn.
All right, I'm sorry I have to jump in there, but what is clear from this discussion is that we need to eliminate completely the discrimination and inequalities when it comes to persons with disabilities accessing healthcare. This has been a special program brought to you by ZTN Prime in partnership with the Poverty Reduction Forum Trust. I really would like to thank my guests for such a interesting and stimulating conversation. Judith Cowlem, Director of the Poverty Reduction Forum Trust, Dr. Christine Peta, Director of Disability Affairs in the Ministry of Public Service, Labour and Social Welfare, and Masimba Kuchera, Disability Consultant. Ladies and gentlemen, thank you very much. I really enjoyed this, and I think it's good to highlight to you. You can see the issues that are there. Please help. Don't treat people with disabilities. They are our brothers and sisters. They are Zimbabweans, and we need to be there for them and support them. And they can and will always, and in fact already are playing a productive part in the development of Zimbabwe. And we need to support the ministry, the NGOs, and of course people with disabilities to make sure that that inequality is eliminated for good within our countries. Again, thank you very much indeed.
Thank you.
Well, that's it for today's show, but obviously we'll be keeping you abreast of some of these issues, hopefully going forward. I'm Andy Hodges. Have a great day, a great weekend, and please, you all be safe.